So this is what I'm going to talk about, a little long-winded title. Development of a simple-minded, user-friendly classification system applicable to all types of lower urinary tract dysfunction. That's me. Okay, simple-minded, easy to use, that's not this, okay? So let's talk about classification for a minute. Here's some quotes. Science is classified knowledge, and development of any science depends upon improved methods of classification. Science consists in grouping facts so that general laws or conclusions may be drawn from them. And from Albert Einstein, make it as simple as possible, but no simpler. So this is just some things about originality. I love the second bullet point. Originality is something that is easily exaggerated, especially by authors contemplating their own work. And the third bullet point is something I think that everyone is familiar with, that quote from Sir Isaac Newton. So the originality for this concept really was Brantley Scott's group. Emilio Quesada was a PM&R person. Brantley, of course, was Brantley. And there was an article entitled Functional Classification of the Neurogenic Bladder Dysfunction, published in 1968. And that's where basically all these ideas about functional classification, simple-minded, et cetera, came from. So classification for lower urinary tract dysfunction should facilitate understanding, facilitate management, avoid confusion, and ideally convey in a few key words or phrases the essence of a clinical situation. The ideal classification system should imply what the clinical symptoms are, the presentation, maybe the urodynamic video findings, the approximate site of neurologic disease or injury. This system that I use does not do that. And it should imply treatment options and be applicable to all types of lower urinary tract dysfunction. So a lot of attempts have been made to describe dysfunction, but they've been all mostly concerned with neurologic disease or injury. Frederick McClellan was a urologist at the University of Michigan. This was his original classification in 1939, okay? Jack Lapides actually took credit for this. All he did was divide atonic bladder into sensory and motor paralytic bladder. That's it. But it was always called the Lapides system. Should have been called the Lapides modification of the McClellan system. These guys were really smart. Bors and Komar. They wrote this book. This was their classification system. As you can see, a little difficult, all applied again to neurology. Everybody remembers Bill Bradley. I mean, Bill was a genius, no question about it. He was a neurophysiologist. Bradley's loops, this one I understood. Okay, this one was like a stroke. This one I understood. This was okay, like spinal cord injury, loop 2. Loop 3, I never understood. I had him explain it to me like 70 times, never understood it. Loop 4 was really the bottom part. It was an injury of the sacrum or distal. Norman Gibbon tried with nomenclature. I put the date up there, 1976. This was his. Bob Crane and Mike Soroki, in their clinical neurourology text, actually one of the earliest texts on neurourology, basically they did it in terms of urodynamics. And this is pretty understandable, but it applies, basically just to people that have detrusor overactivity and basically those who have acontractile detrusors. Okay, Bill tried again with Taggart, and this is what they came up with, something a little simpler than Bradley's loops. Okay, so basically I think, all right, everybody's had enough. So what about this system? Really simple. Okay, principle number 1. The lower urinary tract functions as a group of interrelated structures whose joint function is to bring about efficient and low pressure bladder filling with low pressure bladder storage with normal sensation, perfect continence, and periodic complete voluntary emptying at low pressure. So your lower urinary tract spends 99% of time in filling and storage, 1% of time basically in emptying. So for the purposes of description and teaching, however you want to look at it, you can divide lower urinary tract function, the micturition cycle, into filling and storage and emptying and voiding. And whatever physiologists and pharmacologists would agree or disagree about, everybody would agree on this two-phase concept, totally ignoring physiology and pharmacology. Okay, lower urinary tract filling and storage requires only three things: accommodation of increasing volumes of urine by the bladder at a low pressure, normal compliance, and with appropriate sensation. Bladder outlets got to be closed at rest, stay that way during increases in intra-abdominal pressure, and there can be no detrusor overactivity, involuntary bladder contractions. Even simpler, emptying and voiding. Coordinated contraction of the bladder, smooth musculature of adequate magnitude and duration. Concomitant lowering of resistance of what we'll call the smooth sphincter, smooth muscle of the bladder neck and proximal urethra, and the strided sphincter, the strided muscle that's a part of the urethra, the rhabdosphincter, and the strided muscle that directly surrounds the urethra, and no anatomic obstruction. So what's next logically? Well, you can say then, if you believe that, and everybody does, right? It's just common sense, something you could have thought of if you had enough time. The pathophysiology of failure of the lower urinary tract to fill with or store urine adequately or to empty adequately must logically be secondary to reasons related to the bladder, the outlet, or both. So basically, here's the functional classification. Real simple to begin with. Failure to store, got to be bladder or outlet. Failure to empty, got to be bladder or outlet. So the first place this was published like this was a paper that we wrote about neurogenic bladder dysfunction, published in '76. And there was another review article, basically, that was published in 1981, and from there, just applied it to basically everything. This is probably the best book I ever had anything to do with. I made one mistake, and that was, instead of voiding, it should have been lower urinary tract function and dysfunction. But the system was in here, it applied to everything. It was pretty simple, and people seemed to like it because it was simple. So next, if you keep that in mind, you just fill in the blanks and you tidy it up for yourself as much as you would like. So let's tidy it up because of the bladder, okay, failure to store, FS. It's got to be overactivity, right? Decreased compliance, hypersensitivity, or some combination. Failure to store because of the outlets. Either got to be stress, urinary incontinence, or intrinsic sphincter deficiency, or a combination. That's excluding things like fistulas and excluding things like, I just want to go to the bathroom, I don't really care where, so I'm going to do it right here. And tidying it up for failure to empty because of the bladder, neurogenic, myogenic, a combination, or idiopathic because of the outlet, anatomic obstruction, or functional obstruction, either smooth sphincter dyssynergia or strided sphincter dyssynergia. And once you use this, these are all things that kind of are in your head, and you just sort of do it unconsciously. So how about evaluation? Well, really simple. If you look at urodynamics, this is what it does, right? I mean, what does it do? It evaluates filling and storage by measuring detrusor pressure and total bladder pressure during filling and storage. You can use the detrusor leak point pressure to determine whether there's a hazard to the upper tracts. And you can look at outlet during filling and storage. You can do a urethral pressure profile. I don't think much of that. You can do an abdominal leak point pressure to sort of judge how badly stress incontinence affects somebody. And you can look at it with fluoro basically to do the same thing. Not very good. The emptying phase, we're pretty good at. You can evaluate the bladder during the emptying phase simply by doing a voiding cystometrogram, measure detrusor and bladder pressures. And you can look at the outlet. You can do an EMG. You could do something called a maximum urethral pressure profile. Or if you know someone's obstructed, the best way to tell where is just to use fluoroscopy. During a bladder contraction, the point where the contrast seems to get the narrowest by definition that's where obstruction is. And if you think about flow and residual urine, they're just a method of evaluating the activity of the bladder and the outlet during the emptying phase of micturition, right? If the flow is normal configuration, normal rates, and the residual urine is negligible, then the emptying phase of micturition is probably normal. And you really shouldn't have to do many more studies to figure that out. Now, once you've characterized the abnormality, if you would like a simple, complete menu for treatment options, you're going to carry this around in your head because this is what you do every day. So here's one to facilitate bladder filling and urine storage. And you can make this as long or as short as you want. Behavioral therapy, pharmacologic therapy, not very good. As you'll see in one of my other talks, okay. Bladder over distension, electrical stimulation and neuromodulation, acupuncture and electroacupuncture, interruption of enervation, and finally, augmentation cystoplasty. So, and these are sort of the things you go through, right? When you see somebody who has a failure of filling and storage, you go right down the line. With pharmacologic, you include botulinum toxin. Therapy for the outlet during failure to facilitate or failure to store. Behavioral therapy, pharmacologic therapy, not very good. Urethral occlusion of all sorts of types, including the artificial sphincter, and circumvention with a catheter, intermittent, continuous, or urinary diversion. Therapy to facilitate emptying or voiding. Well, we're not very good at that, right? But these are the ways. External compression, initiating a reflex contraction in a neurogenic patient. Pharmacologic therapy, electrical stimulation, great promise, but no one's really been able to do it very well. Reduction cystoplasty, bladder myoplasty, very complicated and technically demanding operation. Tissue engineering, is that ever going to work? Well, everyone has their opinion about that. Maybe it's something we can talk about during the meeting. Therapy to facilitate emptying or voiding because of some problem related to the outlet. Simple, decreased outlet resistance. Anatomically, at a site of anatomic resistance, prostate, urethral stricture, functional obstruction, smooth sphincter, strided sphincter, or circumvention, clean intermittent catheterization or diversion. So some caveats, if you use the system, failure is almost always relative rather than absolute, and some types represent combinations where you have basically a bladder and an outlet abnormality in the same category. So these are combined problems, right? Detrusor overactivity with bladder outlet obstruction. Detrusor overactivity with detrusor underactivity during emptying. So overactivity during filling and storage, underactivity during emptying. Detrusor overactivity and sphincter incompetence. Detrusor underactivity and sphincter incompetence. And detrusor underactivity and bladder outlet obstruction. So the options when you have a combined problem, you either treat the most severe, the most bothersome, and hope the other one gets better. You can treat both, or you convert it to a single category. For instance, spinal cord injury, involuntary bladder contractions, so failure to fill and store, failure to empty because no voluntary emptying. So basically you convert it all to a failure to fill and store, and then you simply circumvent the emptying problem with clean intermittent catheterization. So that's sort of the way you think about this. So basically, here's a summary. Functional classification represents an evolution of a desire to logically categorize lower urinary tract dysfunction, whether it's non-neurogenic, in a system that doesn't require you to know anything that's detailed about anatomy, physiology, pharmacology, but rather just use your own common sense and general understanding about how the lower urinary tract fills with and stores urine and how it empties, how it functions. As such, the situation can be easily used to serve as a guide and aid not only to a working diagnosis in terms that are understandable, but also as a menu for evaluation and management. So in its present form, this classification has evolved from a long line of people basically who had an idea like it, and really isn't the province of any one person or group. Everybody should keep a list like this of people that they're indebted to, and basically this is mine. Thank you.